Welcome to our sixth webinar for the 2022 Global Year for Translating Pain Knowledge to Practice. I'm Benjamin Farrell, Coordinator of Global Programs here at IASP. We are excited to present this webinar and hear from our speaker today. We will be hearing a presentation on translating pain knowledge of rare diseases and understudied ethnic groups with a focus on sickle cell anemia. IASP are thankful for everyone who could join us today, and remind you that today's webinar will be recorded and available for later viewing at the IASP's Pain Education Resource Center. I'd also like to encourage our viewers to utilize the Zoom's Q&A feature to ask any questions you may have during today's proceedings. During this webinar, I'd also like to ask for everyone to remain muted, cameras turned off, just to avoid any distractions. At this time, it's my honor to introduce our moderator for today's webinar, Dr. Saja Burker. Dr. Burker is an assistant professor of nursing at the University of Florida, whose research focuses on racial disparities in pain using mixed methods to understand the lived experience of older adults with persistent joint pain. Dr. Burker serves on the board of directors for the U.S. Association for the Study of Pain, is a member of the ISP Early Career and Young Leaders Task Force, and sits on editorial boards of the Journal of Pain and Pain Research Forum. With that, I'd like to thank you all again for joining, and I'm happy to pass today's proceedings over to Dr. Burker, and I look forward to hearing from our speaker. Thank you.
Thank you, Ben. So good morning, everyone, and thank you all for joining us today. I hope you can see my screen here. Can I get a thumbs up really quickly, just so I know that you can see my screen, my PowerPoint? Can you see it? I'm sorry, I can't see. Well, I hope you can. Thank you. All right. So you're in for a treat with Dr. Keisha Roach, who will share some great content on sickle cell and pain research. But before I introduce her, I would like you to think about this question. What do you believe is the single most significant or influential discovery in the area of sickle cell disease and pain? And I want you to use the chat feature. You can think about this over the course of the webinar, or if you have some initial thoughts right now, feel free to put that into the chat. And we'll come back to that question at the end of the webinar. So today's speaker, Dr. Keisha Roach, is a nurse scientist with a passion to understand and address acute and chronic pain in patients living with sickle cell disease. She is an assistant professor at the University of Tennessee Health Science Center, with a joint appointment in genetics, genomics, and informatics in the College of Nursing. Her research focuses on the characterization of pain phenotypes, associated biomarkers, and health disparities in individuals of African ancestry, most notably in sickle cell disease and cancer. Dr. Roach is currently a primary investigator on a KO1 training grant titled Contributions of Biopsychosocial Factors in Sickle Cell Disease Pain, and this is funded through the NHLBI. And she also has a small research project which aims to gain an understanding of the AVPR1A gene and its effects on stress and pain in patients living with sickle cell disease. Her research in this area has been funded by the NIA and NHLBI. And I also want to point you to one of the fact sheets for the Global Year theme, and this is authored by Dr. Keisha Roach, Dr. Diachenko, and Dr. Jorns, and it's focused on genetic biomarkers of pain states, and I'm sure she'll reference this in her presentation today. So again, thank you for joining us, and I'll turn it over to Dr. Roach.
Good morning, everyone. I am going to start the presentation now. Can you?
Yes, that's it.
Okay, great. Okay, sorry about that. As I was getting ready to say, we were saying about the focus of this webinar, but I also wanted to point out the picture that I have here. The name of this picture is called 10 Redefined, and the artist is Hertz Nazaire, and he is a person who was living with sickle cell disease. And he had many art pictures depicting life in sickle cell and crisis. And this was one of them. And I think that 10 Redefined speaks volumes to how we rank and look at pain. So I wanted to use this as a part of my presentation today. So our objectives are to describe what is sickle cell disease, what is known about pain in sickle cell disease, and possible targets in the treatment of disease. Also, we will describe the challenges in treating sickle cell, or treating pain in sickle cell, I should say. So what is sickle cell disease? Sickle cell disease is an autosomal recessive group of inherited blood disorders involving hemoglobin. It's caused by a missense point mutation in the 6th codon of chromosome 11 of the beta globin chain, where the DNA nucleotide adenine replaces thymine, causing an amino acid change from glutamine to valine, resulting in crystallization of the hemoglobin. Sorry, one second. I'm having trouble with my, there we go. Okay, resulting in, crystallization of the hemoglobin molecules when the oxygen levels are low. This results in a sickle red blood cell, as depicted in the picture here. Sickle cell disease is the first molecular disease. This was the first published paper on sickle cell disease, and it describes the first patient to be identified with sickle cell here in the US, which was in Chicago. In 1910, James Henrich first described this patient, and in the 1920s, Lamel Digg suggested that pain is due to sickle cells clogging small blood vessels, and this would later go on to be called vaso-occlusive crisis. Linus Pauling in 1949 demonstrated that the disease originates from mutated hemoglobin, and Ingram and Hunt discovered that a single amino acid substitution is responsible for sickle cell disease. In 1995, we were able to had the approval of hydroxyurea, which increases the amount of circulating fetal hemoglobin in this blood system, and it means that the patient's the fetal hemoglobin is less likely to sickle. So that's the benefit of using fetal hemoglobin. Blood transfusions in 1997 were shown to decrease stroke and the incidence in children, stroke incidence in children. And we continued research in the 2000s. And in the 21st century, now we have stem cell transplant, gene therapy, and other targeted therapies. A vaso-occlusive crisis can occur anywhere blood flows, making this disease a multi-system disorder. Every organ system in the body is impacted from an early age. People with sickle cell disease may be plagued with stroke, blindness, heart attacks, leg ulcers, avascular necrosis, and other pain conditions that often require treatment with opioids, especially in adults. We have current therapies and disease-modifying treatments such as stem cell transplant, which is also referred to as bone marrow transplantation. And it is currently the only known cure for sickle cell disease. We also have gene therapy, which is potentially curative or highly disease modifying. This option will aid in removing complications of the disease. And we're beginning to understand the different types of gene therapy that are in use, the differences in their endpoints, and their potential risks for benefits that will be key to optimizing the long-term use of this therapy. And while these therapies are promising, these therapies do not cure pain. Patients still get chronic pain post-transplant. So a little bit about the inheritance of sickle cell disease. The risk of a child inheriting sickle cell disease or sickle cell trait is as follows. If both parents have sickle cell trait, the child has a 50% chance of inheriting sickle cell trait, a 25% chance of inheriting sickle cell disease, and a 25% chance of inheriting 2 normal genes. If the parent has sickle cell trait and the other parent has 2 normal hemoglobin genes, the child has a 50% chance of inheriting sickle cell trait and a 50% chance of inheriting neither trait nor disease. If one parent has sickle cell disease and the other parent has sickle cell trait, the child has a 50% chance of inheriting sickle cell trait and a 50% chance of inheriting sickle cell disease. If one parent has sickle cell disease and the other parent has 2 normal hemoglobin genes, the child has a 100% chance of inheriting sickle cell trait, but not the disease. If both parents have sickle cell disease, then the child has a 100% chance of inheriting the disease. Can you guess who has sickle cell disease from this photo or from this slide? All of them, yes. So now we're going to talk a little bit about the epidemiology of sickle cell disease. Sickle cell is the most common hemoglobinopathy and is a global health issue. It affects approximately 300,000 newborns each year in India, the Middle East, and Sub-Saharan Africa, and 100,000 Americans. In the US, sickle cell disease disproportionately impacts African Americans and Hispanic Americans. The highest incidence of sickle cell disease globally is Nigeria, the Democratic Republic of Congo, and India. In Africa, which has 75% of the global sickle burden, greater than 50% of the affected children die before their 5th birthday. And this is primarily due to infections, pneumococcal and other bacteria, malaria, and then 5% of all under 5 deaths in Africa and up to 9% in West Africa are related to sickle cell disease. Sickle cell occurs here in the US, sickle cell occurs in about 1 out of every 365 Black or African Americans, 1 out of every 16,300 Hispanic or Hispanic Americans, and 1 out of every 65,000 white American births. Sickle cell mortality in the US. So sickle cell related death among Black and African American children less than the age of 4 fell by 42% from 1999 through 2002. And this coincided with the introduction of the 7-valent pneumococcal vaccine. Survival has increased dramatically in sickle cell disease in the US since the first description by James Hendrick in 1910. Early death is still the rule in resource-poor environments. The first major improvement in survival came with the recognition that septicemia was a major cause of death in the young children with sickle cell disease. And this was often before they had been diagnosed, since characteristic clinical symptoms are often not evident until the 2nd year of life. Early aggressive treatment with antibiotics and the use of blood transfusion for acute chest syndrome greatly improved survival of sickle cell patients into adulthood. Major morbidity remains, however, especially stroke and pain. Once they reach adulthood, patients with sickle cell disease suffer from chronic organ damage due to repeated sickling and vascular damage. Death is usually due to chronic organ failure. Lungs, kidneys, and cardiac failure are usually the primary causes. Recent work has shown that chronic vascular damage is due to adherent erythrocytes and hemolysis. Intravascular hemolysis interferes with nitric oxide vasodilating systems in 2 ways. 1, it releases red blood cell arginase in the plasma, lowering the synthesis of nitric oxide. And two, it increases plasma-free hemoglobin, which directly scavenges endothelial-derived nitric oxide. So pain in sickle cell disease. The hallmark symptom of sickle cell disease is intense pain that can start during infancy and increases in severity throughout the lifespan, leading to hospitalization, poor quality of life, increased healthcare costs, and early mortality. Pain in sickle cell disease is different from other pain states. The pain may begin in infancy. These patients may suffer from both chronic and acute pain and live with fear and anxiety because location, frequency, duration, and severity of the disease are unpredictable. As described by Wally Smith et al. In his Pisces project, this slide represents the common pain sites which hurt an average of more than 1/3 of pain days in adults living with sickle cell disease. So with the most frequent being knee, shin, and low back and hip pain, and some of the least frequent pain days are pelvis and jaw. Factors that contribute to pain. In sickle cell disease, there are multiple factors that contribute to the pain experience. Multiple biopsychosocial factors known to contribute to other pain conditions have not been studied in sickle cell disease. Multidisciplinary pain research will aid in opening this path. So we have biological factors, psychological factors, and social factors that all lead to pain. So the pathophysiology. As previously described, there are many sickle variants around the world. The variants result in differing degrees of disease severity. Molecular pathophysiology of sickle cell disease is as follows. So we start with a single nucleotide polymorphism in the beta globin gene, which leads to substitution of valine for glutamic acid in the beta globin chain. And this is followed by deoxygenation in the mutated hemoglobin molecules that polymerize to form bundles. And then the polymer bundles result in erythrocyte sickling. So we're going clockwise, which in turn results in impaired rheology of the blood and aggregation of sickle erythrocytes with neutrophils, platelets, and endothelial cells to promote stasis of blood flow, referred to as vaso-occlusion. And vaso-occlusion also promotes ischemic reperfusion injury. The complex pathobiology of sickle cell disease suggests that pain may occur via nociceptive, inflammatory, and neuropathic mechanisms. Each pain state generates its own neurochemical signature in the periphery and the central nervous system, and requires different analgesic treatments. So the nociceptors on the peripheral nerve terminals are stimulated by noxious environment. This noxious environment stimulates the primary afferents and the second order neurons on the dorsal horn. Repeated vaso-occlusive crises may cause sensitization of peripheral and central nervous system, potentially leading to impaired therapeutic responses. Recurrent vaso-occlusive crisis may lead to sustained noxious environment, causing the central nervous system to be constantly hyperexcitable, this leading to the transition from acute to chronic pain. Vaso-occlusive crisis is episodic, recurrent, and unpredictable, as I previously stated. The microvascular obstructions cause impaired oxygen supply, leading to an ischemic reperfusion injury, inflammation, oxidative stress, and endothelial dysfunction. Acute pain episodes due to vaso-occlusive crisis causes its release of the mediators that contribute to the inflammatory milieu, triggering nociceptor activation. So for one, we have from the cartoon that I'm showing here, we have epithelial cells activate in response to an inclusion, releasing cytokines, increasing the extravasation of monocytes. And then this leads to the increase in inflammatory cells, signaling the release of cytokines surrounding the nociceptor terminals. And third, we have the nociceptor is activating and releasing substance P, or calcitonin gene-related peptide. Fourth, this results in a feed-forward mechanism contributing to nociceptor sensitization. Chronic pain in sickle cell disease refers to pain persistent on most days lasting over 6 months. It can start during childhood, and the prevalence increases with age. By adulthood, over 55% of patients experience pain in over 50% of days. 29% report pain on 95% of days. The true prevalence of chronic pain in sickle cell disease is likely to be underappreciated, as it's mostly managed at home. Patients with chronic pain and sickle cell disease frequently seek acute care for exacerbation of underlying chronic pain that's difficult to distinguish from their usual acute vaso-occlusive crisis. Chronic pain in sickle cell disease has profound consequences in patients. It's often associated with comorbid psychiatric illness like depression and anxiety. And this is not dissimilar from other chronic pain syndromes. They may also experience challenges with sleep hygiene, various somatic symptoms, and chronic fatigue that impair the quality of life. How to best treat chronic pain in sickle cell disease is not definitively established yet. Targets to treat pain. So current and future therapies for targeting molecular pathobiology of sickle cell disease. First, we have drugs that are capable of modulating hemoglobin polymeration, erythrocyte dehydration, and hemoglobin oxygen affinity. We also have drugs that are capable of preventing vaso-occlusion by inhibiting adhesive interactions between leukocytes, platelets, and endothelial cells and erythrocytes. We have drugs that are capable of preventing endothelial dysfunction by scavenging hemoglobin and reactive oxygen species or promoting nitric oxide synthesis. Drugs capable of preventing the sterile inflammation by scavenging heme and reactive oxygenation species, digesting neutrophil and extracellular traps, inhibiting toll-like receptor 4 or inflammasome activation, and inhibiting interleukin-1 beta-dependent innate immune signaling. Drugs approved by the USDA are shown in bold font, and this is hydroxyurea and L-glutamine. So let's talk a little bit about the pain experience from the patient's perspective. So racial and ethnic disparities are pervasive in our healthcare system. Pain is no exception. Oligoanalgesia, or ineffective management of pain, is found at a higher rate in racial and ethnic minorities. Unrelieved pain results in unnecessary suffering, loss of days from work and school, delayed healing, functional disability, and increased hospital length of stays. So despite the high prevalence of painful conditions, African Americans are routinely undertreated for their pain. When patients with sickle cell disease have severe pain crisis that results in visits to the emergency department, they typically have significantly longer wait times for pain control compared to other ethnic and racial groups in the hospital setting. Sickle cell pain can be further exacerbated by stress and perceived injustice. Currently, opioids are one of the main tools used to treat pain of sickle cell disease. In addition to this, patients with sickle cell disease have been heavily impacted by the opioid crisis. In many cases, they're not able to get medications with which they had their pain well controlled for years, because physicians have been pressured to decrease the number of opioid prescriptions. Now, physicians must follow stringent opioid prescription guidelines that may legitimize biases that some healthcare providers already have. Patients with sickle cell disease are often stigmatized and viewed as drug-seeking, when in fact, most don't become addicts. The CDC responded with a formal warning against the misapplication of guidelines in specific patient populations, including sickle cell disease. Most patients continue to report high levels of stigma and opioid phobia in their interactions with healthcare providers, whose focus on reducing usage of pain medication without offering viable alternatives. So now we're going to talk a little bit about the research in sickle cell disease. So in both Berkeley and Towns, the mouse alpha and beta hemoglobin alleles have been knocked down, and a human alpha and beta globin alleles have been inserted. Wang et al. Reported findings that these mice demonstrated neuropathic pain within 3 weeks of birth. Both sickle mice displayed many of the pathophysiological changes observed in patients, including anemia, organ damage, hypoxia-induced cell sickling, and pain sensitivity. Similar findings for clinical studies using QST, quantitative sensory testing, found that patients with sickle cell disease report significant thermal and hyperalgesia and cool and cold allodynia compared to matched controls. While examining neuropathic pain in sickle cell disease, it became clear that adjuvant analgesic treatments should be explored. Since pain in sickle cell disease can be neuropathic in origin, anticonvulsant and antidepressant medications, which are established therapies for neuropathic pain, are being explored in sickle cell disease. We have CAMK2, calmodulin-dependent protein kinase, which is I already said CAMK2, but this is a multifunctional protein kinase that is a key component of calcium signaling pathways. CAMK2 alpha has been implicated in chronic inflammatory pain and neuropathic pain. It has also been shown to play a critical role in opioid-induced hyperalgesia. CAMK2 is also known for its role in neuropathic pain, and trifluoroperazine is a potent CAMK2 inhibitor. Researchers studied trifluoroperazine in adults with sickle cell disease. They looked for adverse effects and pain intensity reductions. Patients received a single dose. The researchers measured adverse effects, pain intensity, and supplemental opioid analgesics. The dosages ranged from 0 to 10 milligrams, and participants reported moderate to severe effects at the higher doses. 8 subjects reported 50% reduction in chronic pain without severe sedation or supplemental opioid analgesics. One of the subjects had dystonia 24.5 hours after the 10 milligram dose. The analgesic effects lasted at least 24 hours in 3 of the patients. Sedation was resolved with caffeine, and dystonia was resolved with diphenhydramine. This figure represents visual analog scores of the 18 subjects during the 24-hour study. The green symbols represent 50% reduction of the baseline. The blue symbols represent 50% from baseline, but contaminated by a supplemental analgesic, which is represented by the red vertical line. In mice with opioid-induced hyperalgesia, CAMK2 activity was correlated with mechanical allodynia and thermal hyperalgesia. This drug may have both beneficial and harmful effects that require further study because the CAMK2 knockout mice did not survive the treatment. Studies examining long-term adverse and analgesic effects are ongoing. There was one particular patient who had 38 acute care utilization events in 1 year and actually spent 180 days in the hospital. And this participant got the best benefit from the trifluoroperazine dose. This is therapy based on a molecular evidence and was carried back and forth between the lab and the bedside. Trifluoroperazine is expected to be most effective in chronic but not acute types of sickle cell pain. Studies of quantitative sensory testing in sickle cell disease showed that adequate reference values for patients' commonly reported pain sites are unavailable from healthy, pain-free African Americans, which limits the interpretation of the results. The study purpose was to characterize QST values in healthy, pain-free African American adults and older adults whose prior pain experiences and psychological status were also measured. We examined the QST values for differences by sex, age group, and body site. The temperature of adaptation for this study was 32 degrees C. Participants reported warm and cool detection at levels similar to those published in other populations. Average heat pain threshold was 37.8 degrees C, and average cold pain threshold was 26.3 degrees C. And that pain was rated on an average of 2 out of 10. In contrast to other studies where the values were 43 to 45 degrees for heat pain and 10 degrees for cold pain, in which the rated average pain was 6 out of 10. The average mechanical pain threshold was 16.7 grams of force. There were no significant differences in pain thresholds by age or sex. Overall, this healthy sample of African American adults had average thermal pain thresholds within 6 degrees of the temperature of adaptation that were not significantly different by age or sex, but lower than those other published reports. Differences in responses to thermal and mechanical stimuli for upper and lower body sites were consistent with previous research. We believe that these results can be used as controls for African American adults with sickle cell disease and tested when they're tested with the same protocol. Additional research is needed to resolve differences in QST values observed with different protocols and to establish normative QST values for healthy, pain-free African American adults with consideration of geographic region within the US and genetic admixture of the participants. Some of the results may be attributed to the instructions provided to the patient at the time of testing. Call your pain a number. In another published study, the QST values were used to compare thermal thresholds with patients with sickle cell disease. Patients with sickle cell disease had even lower thresholds to mechanical stimuli and reported higher pain intensity scores to all thermal and mechanical stimuli at non-painful body sites. Twice as many patients showed sensitization at the anterior forearm, and 18% exhibited some element of central sensitization. This means they showed persistent allodynia and hyperalgesia, which may excuse me, be indicative of neuropathic pain and could contribute to the paradigm shift in the treatment of sickle cell pain. Genetic variability is suspected to have a role in the perception of pain. For example, some of these variations affect metabolism of medications, which may result from alterations in pathways. Because of this potential variability, approaches to gain a better understanding of pain may be found by exploring genetic markers such as single nucleotide polymorphisms, also called a SNP. A SNP is a single base pair substitution that may result in changes in the downstream sequence, protein expression, or phenotypic changes in appearance, disease risk, and response to drugs or the environment. For example, a large number of patients with sickle cell disease have a cytochrome P450 2D6 polymorphism that decreases the conversion of codeine to morphine, resulting in decreased analgesia. Our group prioritized and examined the genotype and allele frequencies of 115 SNPs from 49 candidate pain genes in 199 adult African Americans and pediatric patients of African origin with sickle cell disease. Analyses were performed and compared with available data from the public databases. Genotype and allele frequencies of a number of SNPs were found to be different between our cohort and those from the databases, and between the adult and the pediatric subjects. We found that genotype and or allele frequencies for a number of SNPs were statistically different between our sickle cell cohort and the literature data, and for African Americans, and also between our adult sample, primarily African American, and our pediatric sample of primarily West African Nigerian origin. We reported on patients with sickle cell disease who participated in a study of those of the associations between genetics and pain phenotypes. We chose the AVPR1A gene, one of the SNPs, RS108-77969, because of its relationship to and my interest in pain and its relationship to stress. We postulated that the AVPR1A polymorphisms might help explain some of the clinical observations in sickle cell pain, especially since in patients with sickle cell disease, clinical factors such as pain and stress have been associated with increased risk of healthcare utilization. But it's not known if the presence of the AVPR1A SNP plays a role in this observation. Yes?
We're at 1040.
Okay, a previous exploratory analysis of COMT gene, their SNP and the DRD3 SNP by our group suggested possible contributions to pain-related care and acute care utilization in people with sickle cell disease. Our aim was to extend the analysis to genes spanning haplotypes in COMT and DRD3 SNPs to investigate possible associations with pain intensity and pain-related acute care utilization in the sickle cell cohort. We found COMT and DRD3 haplotypes associated with pain-related sickle cell features, suggesting that in future studies, more emphasis should be placed on cis effects of the SNP alleles in evaluating genetic contributions to sickle cell pain, and acute care utilization for pain. With the exception of stem cell transplant, which is curative, the treatment for sickle cell disease has not changed in many years. Until recently, the treatment consisted of oxygen, IV fluids, hydroxyurea, antibiotics, and other medications. Within the past 5 years, 3 different drugs have been approved by the FDA for the treatment of sickle cell disease, particularly to reduce vaso-occlusive crisis. Other emerging therapies are Arginine supplementation, which is shown to enhance nitric oxide bioavailability and decrease hemolysis and oxidative stress in mice. In a placebo-controlled randomized controlled trial performed in Nigeria, showed a significant reduction in time to vaso-occlusive crisis, resulting in a resolution, length of hospital stay, and total analgesic requirements. As a result, arginine may be a relatively inexpensive treatment for treating pain crisis in sickle cell disease. Also, studies are being done in cannabinoids. These are known to have both analgesic and anti-inflammatory effects and may ameliorate some of the mast cell activation, leukocyte trafficking, and adhesion, and neurogenic inflammation, oxidative stress, and hyperalgesia via the cannabinoid receptors 1 and 2. So cannabinoids show promise as a potential therapeutic for sickle cell disease, but more clinical studies are needed regarding their efficacy. And while they show promise in pain management therapeutics, their use remains controversial. And then lastly on this slide for the newer studies, the prevalence of sleep disturbance in adults with sickle cell disease has been reported to be nearly 70%. In a previous study of patients with sickle cell disease, it was found that subjective parameters of sleep, including duration, fragmentation, and efficacy, could be used to predict clinical pain. Recent studies have shown that a link between sleep, vasoconstriction, and pain. And so given this therapeutic approaches, given this information, therapeutic approaches aimed at optimizing sleep may be helpful in treating pain in sickle cell disease. So real quickly, some of the translational methods to improve the outcomes include environment, omics, food supplements, and translation. And we can, for the sake of time, I'm going to go ahead past this slide, but these are some of the things that we can use to help improve some of the outcomes. And for translation, bench to bedside for biomarkers of pain and prevention and treatment can be used to help integrate some of the effects that we see in pain and sickle cell disease. So suggestions for future studies include identifying biomarkers for pain that have been identified as high research priority. QST may have been underestimating the sensitivity in the African American population. Norms from the literature were inadequate. We need cohesive measures and procedures, and we need to listen to patients, allow them to feed the paradigm. Can the environment influence pain? These are also things that we can consider in our research. Diet, nutrition, company, social isolation, loneliness, stigma, sleep, pleasure, trauma, depression, anxiety, and food supplements. Now that you have an understanding of the pathophysiology and treatment strategies in sickle cell disease, this slide is a representation of how it all comes together in human and in mouse models. This overview includes recently approved therapies and those in development for treating pain in sickle cell disease. Different treatment strategies are being employed, including those with sickle red blood cell pathology, sensory nerve transmission, and top-down mechanisms for pain. Treatment study primarily in humans are outlined in blue, whereas those studied primarily in the mouse are outlined in yellow. For therapies in which both mice and humans were performed, a green outline is used. Audiovisual relaxation, CAMK2, dependent protein kinase, CBT, CoQ10, nociceptive opioid receptors are all things that we can continue to look at to help to reduce and modify the pain in patients who live with sickle cell disease. And so I would just like to say at the end of this presentation, in memoriam, in the past year, we've lost many pioneers who devotedly represented and defended those challenged with sickle cell disease. And I would just like to acknowledge them here. Hertz Nazir, Carlton Haywood Jr., Kwaku Ohene Frimpong, and Samir Ballast. Thank you.
Thank you, Dr. Roach, for that very comprehensive presentation on sickle cell disease and pain research and some of the translational discoveries. And so I want to open this up now. We have about 12 minutes for questions. And so if you have questions, please put those in the Q&A. And then I will present those questions to Dr. Roach. But while you're doing that, Dr. Roach, I will start us off with a question. Okay, so if you had to rank the following priorities for sickle cell disease, how would you rank them 1 to 6 and why? Okay, so the choices are preventing vaso-occlusive crises through novel therapies, addressing reproductive health, improving quality of life, increasing federal funding, improving access to an equitable delivery of evidence-based care through innovative healthcare delivery models, or identifying a cure.
Oh, wow. Those all rank 6 for me. But I think that right now, preventing vaso-occlusive crisis through novel therapies is incredibly important, along with the reproductive health. Both of those are, all of them are incredibly important. It's very difficult to rank one higher than the other. Of course, with reproductive health, it's important for us to help people understand. You saw that slide with the different permutations of how patients with sickle cell disease, how the disease is transferred from the parents to the child. That can be really a lot for patients to grasp when doing family planning. So of course, that's very important. And then as far as the therapies go, it's important to continue finding ways to eradicate, the vaso-occlusive crisis portion of sickle cell disease. And also with knowing that, even with these therapies and the strategies used to be able to deliver those therapies, sometimes it's not everybody is able to tolerate the treatment to prepare the body for the different therapies that we have in place to help resolve sickle cell disease. So really all of these are different strategies to combat the same problem. And you have to come at it from different ways because there's no one size fits all.
Mm-hmm. Yeah, I agree that I think these are all high priorities. And so someone in the chat wants you to go back to your emerging treatment slide.
Okay.
And so is there a particular question about that slide? I'm not sure. Emma Stoy?
And yes, sure, I can go back to that slide. 1 second, I'm going to share my screen. Oh, I think, is this the one that you're referring to?
It's the emerging treatment. So maybe your other slide, keep going back. Go back, wait. About treatment that we could manage through physical therapy. So wherever.
Uh-oh. I don't remember where that slide.
Okay. Is there a particular question that you have about the emerging treatments that you would like to ask? The previous one that you showed. So maybe the one at the very beginning.
Was this the one you're referring to?
It said yes.
Okay.
And what's your question about that slide, or did you just want to look at it again?
So this slide is
Okay, they just wanted to see it again.
okay, this is from Snud et al. And this came out in 2019, and it was in the annual review of pathology.
Thank you. So Gina would like your answer to the reflective question that I posed at the beginning of the webinar, which was, what do you think is the single most significant or influential discovery in the area of sickle cell disease and pain?
Oh, wow.
What's the game changer for you so far?
Yeah. So I think about, the understanding of fetal hemoglobin. Sorry, I don't know why this keeps going off. The understanding of fetal hemoglobin was a big game changer. I mean, understanding, I don't know, the importance of hydration and sleep. I mean, all of these are just, we have this big problem that we're trying to address, and each piece is important toward getting us to our goal. And so it's really difficult for me to say that one is more important than the other, because not one person might benefit from just one answer.
Mhm.
Different people benefit from different approaches. So I just think that all of them, I mean, if anything, recognizing that sickle cell is a disease, recognizing that, we have different polymorphisms that make us metabolize the medications in different ways, to helping address the stigma. I mean, it's just so many pieces that are intertwined that, I just have a difficult time saying one over the other.
Mhm.
All right.
We have another question here. This is from Dr. Merriweather. She says, great talk, Dr. Roach. With curative therapies such as stem cell transplants or other therapies, how does that affect the pathophysiology of acute or chronic pain?
Say that question again, Star.
Yes, that's fine. With curative therapies such as stem cell transplant or other therapies, how does that affect the pathophysiology of acute or chronic pain?
Well, there are many ways that can be impacted, but so for the acute and chronic pain, if you're not having crisis as much, the possibility of you having chronic pain is decreased. But in the instances that you do have some degree of chronic pain, maybe it's not as severe, and depending on the severity, maybe you're not leading into from acute to chronic pain. I think I kind of said that backwards, but yes. So, you're not having as much acute pain.
Mm-hmm.
And it may not have the opportunity to translate into chronic pain.
Right. And so just to follow up with the curative therapies, then if they have other types of chronic pain, let's just say they have osteoarthritis, that doesn't necessarily treat or impact that type of pain, correct?
Correct.
Okay, got it. So they still could have some type of chronic pain, but it may not be related necessarily to the sickle cell.
Right.
Okay.
And because people are living longer, they're still starting to acquire diseases of aging.
Right, yeah. Okay. Our next question is from Minkia Wayne, and it's, do sickle cell disease patients show headaches, and how do you treat it?
Yes, sickle cell patients definitely get headaches, and depending on why it's originating, typically they treat their headaches the same way that people without sickle cell disease treat their headaches. They'll just take a medication that helps that. That helps the same way we do.
Okay.
So if they are having headaches because of a crisis, so a stroke, which is typically identified by people having strokes who don't have sickle cell as the worst pain I ever had. I used to work in the neuro unit. That of course is a medical emergency, and you're going to go to the hospital, to the emergency department for that type of pain.
Okay, so we have one more question, and we're almost out of time here, but I do want to ask you this question. This is from Dr. Lakeisha Cousin. She says, I enjoy your presentation, Dr. Roach. You mentioned fetal hemoglobin. Have you heard about any new research about anti-sickling properties in research that sounds promising to you? So new research on anti-sickling properties.
In fetal hemoglobin. Actually, no, I have not. I have not heard of any. I just know that in our clinic, for those who are able to tolerate it, a percentage of the patients take hydroxyurea, which increases the amount of circulating fetal hemoglobin. And those cells are less likely to sickle.
Okay.
But in terms of new therapies related to that, I haven't heard about it. That doesn't mean that it doesn't exist. It just means that I haven't heard about it.
Yeah, so it seems like there are numerous opportunities for research in sickle cell disease, a number of issues to address. And we thank you, Dr. Roach, for presenting your research on how you're addressing sickle cell, but also just talking about in general, the discoveries and how they've been translated into practice. So I just want to say thank you for your presentation. And now I'll turn it back over to Ben, who will give some final remarks.
Thank you. And yes, I want to echo Dr. Booker and thank you so much for a fantastic presentation and a very insightful Q&A session as well. So as a reminder, this webinar will be uploaded to IASP's Pain Education Resource Center for later viewing to both members and non-members of IASP, completely free of charge. Our next and final webinar for the 2022 Global Year campaign will take place in December. So please keep an eye out for any IASP's communications about the Global Year on how to register and get involved. So thank you all once again for joining us, and have a great rest of your day.
Thank you. You have a great rest of your day too.
Everybody.
Thank you, everybody.